Hi, everyone. Thank you for joining us for another ForceNet webinar. My name is Chad Cook. I'm one of the principal investigators of ForceNet, and we do have the ForceNet team here with us as well. If you're interested in these webinars, we have created a YouTube library, and we have several wonderful videos if you're interested in watching some from over the years. We have another great one today. I think it's very timely and it's certainly going to be interesting. And we haven't really covered this area before. Let me give you some parameters on how we do this before I introduce our speaker. We do keep everyone on mute the whole time, and if you have questions that arise, and you can post these questions at any time, we do take questions at the end, you will actually incorporate those into the chat room. I will be the moderator, so I will watch those questions, consolidate them, and then interact with Dr. Ken Weber. So our speaker is Dr. Ken Weber. He is a clinician scientist who was trained as a chiropractor and a neuroscientist. He is presently an assistant professor in the Division of Pain Medicine at Stanford School of Medicine, where he directs the Neuromuscular Insight Lab. His research seeks to make MRI more quantitative by combining machine learning and advanced brain, spinal cord, and muscle imaging, to develop markers that track sensory and motor function. He aims to use these techniques to improve diagnosis, prognosis, and management of multiple musculoskeletal, neurological, and neuromuscular conditions, including pain. So, everyone, let's welcome Dr. Ken Weber. Ken, the floor is yours.
All right, thank you for the introduction, and I'm thrilled to be presenting to you this afternoon. I've enjoyed attending several of the ForceNet presentations. I look forward to discussing our research using quantitative MRI techniques to advance the management of spinal conditions. I have no financial or competing interest to disclose. So I direct the Neuromuscular Insight Lab within Division of Pain Medicine at Stanford. I also have courtesy appointments in radiology and neurosurgery. And we have a very interdisciplinary team, which includes neuroscience, physical therapy, chiropractic, pain medicine, medical physics, radiology, neurosurgery. Here's faces of just my immediate team members who have contributed to much of this work. We are fortunate to have several ongoing NIH-funded research studies, including 2 studies in cervical myelopathy and cervical radiculopathy. And we're one of the few research groups in the US with expertise in functional spinal cord MRI, which is technically very challenging and a component of our funded projects, but I'm not going to be discussing that today. Instead, I'll be focusing on structural imaging. We closely collaborate with Stanford's Pain Management Center, the Richard M. Lucas Center for Imaging, as well as the Neurological Spine Disorders Clinic, the Orthopedic Spine Center, and the Palo Alto VA Medical Center. As Chad mentioned, I'm clinically trained as a chiropractor. I then went and completed a PhD in neuroscience. And when I began my PhD, I was set on being a manual therapy researcher. But you can't always control where your PhD trajectory goes, and instead I focused on method development around spine and spinal cord imaging. And then over the last 15 years, I've been trying to figure out how to best develop and then potentially use these techniques to better understand spinal conditions. To date, most of our work has been in the surgical space, trying to get at mechanisms of neurological injury as well as surgical response. And I'm just finally starting to apply these to non-surgical treatments through collaborators and being able to start to study manual therapies. So I'm looking for collaborators in the space, and I look forward to your feedback at the end of the talk. So the backdrop of this lecture is our interest in spinal conditions, which includes traumatic spinal cord injury, non-traumatic degenerative myelopathy, radiculopathy, and neck and back pain. Spinal conditions are the leading cause of physical disability and pain, and we're working towards a future where we can understand the unique characteristics of each patient to provide them with a diagnosis, an effective treatment, patient-tailored treatment plan, and prognosis, all with a high level of confidence. As you know, unfortunately, we're really far from this vision, and I believe it's due to the complexity of spinal conditions and the limited tools available to assess this complexity. The pathophysiology of spinal conditions extends beyond the central nervous system to include the peripheral nervous system, the musculoskeletal system. Injury to the spinal cord or nerve roots disrupts descending motor commands and sensory feedback, leading to weakness, discoordination, impaired mobility, as well as muscle atrophy and compositional changes. Pain, which is a product of the brain, is a key component of spinal conditions and often the chief complaint of patients. And spinal pain itself is multifactorial and complex. Several tissues can contribute to the generation of spinal pain. And overall, we have low diagnostic certainty to know which tissue or tissues are the source of pain. Pain is also more than just that sensory input, but it's the multiple biological, psychological, and sociological factors that all come together and shape an individual's experience of pain. So I believe to truly make progress in the management of spinal conditions, we need to take a comprehensive approach and be able to study these systems collectively. And I feel an understanding of this interconnectedness is going to be key to understanding human health and the discovery of breakthroughs in the treatment of spinal conditions and bring us closer to precision medicine and spine care. So over the last 15 years, I've been contributing to the development of tools to assess the brain, spinal cord, and musculoskeletal system as not previously possible. Much of this work has been on the improvements in image acquisition and analysis to make medical imaging, especially MRI, more quantitative. Today, I'll be focusing on our work in spinal cord, as well as muscle quantitative MRI. So what do I mean by quantitative imaging? So let's give an example of a patient with neck pain who's been unresponsive to treatment for 6 weeks, has some pain and tingling radiating into the right upper arm, has started to experience some clumsiness in the right hand. You feel at this time that imaging is appropriate, and so you order an MRI. And here you can see a mid-sagittal T2 weighted image, which shows an obvious disc lesion at C5, C6. Accompanying that MRI, you'll of course receive a report describing the imaging series. At C5, C6, the radiologist identifies a moderate posterior disc osteophyte complex, mild bilateral facet, and uncovertebral arthropathy, moderate spinal canal stenosis, mild bilateral neural foraminal narrowing. And then there's other changes at adjacent segments as well. So we're getting this rating of mild, moderate, severe. You're getting the side of the location of these changes. But overall, this report is certainly helpful, but it's more narrative and more qualitative than quantitative. Which of these findings, relate to the patient's upper limb symptoms? And can we do a better job at assessing the pathology on imaging and linking it to the clinical presentation? So if there's anything I can get across here, it's this. I think we can do a better job. And that's because we're missing so much information, so much from the images. They contain a lot more information. We just need to be able to measure it. So through quantitative imaging techniques, we can have a better understanding of what is normal, what is not normal, and hopefully have a higher level of confidence of which imaging findings are related to the patient's clinical presentations. So what can we measure? We can pretty much measure anything. For example, we could look at maybe vertebral alignment here. We could look at disc height, disc shape, vertebral height, spinal cord, anterior, posterior diameter. And these are just 2D measurements, but we can expand this to studying size and shape of the spinal structures in 3 dimensions. We can even get a composition of these structures, and with techniques such as functional MRI, we can non-invasively assess neural activity. So the possibilities are really endless. You just need to measure it. To do these measurements manually, is too costly and not possible. But with the arrival of new AI-powered computer vision algorithms, we can now measure, almost anything. And the backbone of these advancements in AI are neural network statistical models. Neural network models consist of an input layer, which is your data or features. There's multiple layers of nodes connected by weights, and then a final output layer, which is your prediction. And this prediction could be categorical or continuous for classification or regression problems. Given their complexity, it's not possible to mathematically derive the optimal solution of these networks. Instead, these models are trained in an iterative process, and the models learn the weights of the connections between these nodes to make accurate predictions of the data. So to train a model, you can pass some data through the model. You can calculate an error here to see how off you are in that prediction. And then you can update the model weights to reduce that error. And then you can continue to repeat this process. And you can see here that the loss is continuing to go down. And when the loss is at a level that is satisfactory, for your job, you're happy with it, then you can stop training and say that you have that model's trained, and then you can apply it to your research. There's a special type of neural networks called convolutional neural networks. And in these networks, the nodes are connected to local regions of an input image, which preserves the spatial structure within the network. And convolutional neural networks have really revolutionized computer vision tasks. And with the release of open source tools like PyTorch and MONAI, it's lowered the cost to develop and train these models. And basically, if you can accurately identify anatomy or pathology in an image, it's now fairly straightforward forward to develop a computer vision model to automatically measure this anatomy or this pathology. So here's an example of a convolutional neural network that we've trained, which on T2 weighted axial lumbar spine images. And so you can input a T2 weighted image into the model, and then within a few seconds, it spits out a segmentation image. And using this image here, you can identify where these muscles are within the image. You can extract information on the size, the shape, and composition of muscles, depending on what type of MRI you're using. So for this talk, giving an introduction into kind of these computer vision models, I'm going to start with our work in muscle imaging and what we've done and kind of where we're going in this area. So MRI is considered the gold standard for assessing muscle. It's non-invasive, provides high resolution volumetric images. So it's a 3D a tool, and you can create highly accurate models of the anatomy. You can also get at tissue composition and other properties depending on the type of MRI being used. We commonly use Dixon fat water MRI, which allows us to assess the amount of fat within a muscle. We're also using diffusion imaging to be able to also get at information on microstructure within muscle. Reduced muscle health is observed by atrophy and increases in intramuscular fat and is seen in many chronic conditions, including pain. So this brings me to our first study attempting to automate the assessment of muscle health following a whiplash injury. At the time, this is pre-2019, the analysis required manual identification of muscles. You needed to have someone physically go in and identify the muscle boundaries at every slice in the area that you're interested in assessing. And this requires significant time and significant anatomical and radiological expertise. And on top of that, motivation, because manual segmentation is extremely boring. And if anybody spent too much time on this, it's a very tough task. James Elliott had just completed, he's now at the University of Sydney and directing research at the Kolling Institute. But he was at Northwestern, where I completed my PhD. And he had just completed a longitudinal study in 100 patients post-motor vehicle collision. And they had fat water imaging of the cervical spine at 2 weeks, 1 month, 3 months, and 1 year post-injury. So if you do the math, that's 400 data sets for somebody to go in and be able to analyze. And if you wanted to assess a single left-right pair of muscles in this data set, I estimate it probably would take about 400 hours, which is really not possible. So at this time, I was taking a course here in computer vision models as part of my postdoc. And I thought this was an excellent problem for me to try to solve, that I could try to solve with the techniques that I was learning. So we trained a convolutional neural network to automatically identify the left and right semispinalis cervices and multifidus. And here are the results. What took hours could be completed in seconds with high accuracy and reliability for muscle volume and intramuscular fat. On the left here are examples for the 3 human raters, and then on the top is our model, which we frequently even looks better on some instances than the human raters. Next, we demonstrated that the automated muscle health measures were correlated with health outcomes in a small subset of 39 participants. Muscle size was associated with neck pain and neck disability, while muscle fat was higher in those with persisting whiplash symptoms versus those who recovered. Shortly after this, we scaled up our modeling from one pair of muscles to seven pairs of muscles. So manually identifying seven pairs of muscles, takes hours per data set, 4 to maybe even up to 8 hours to do this manually. And I really only know 3 people in the world that really have the expertise or the motivation to do this. Then in 84 participants, we showed that intramuscular fat is higher in the deep cervical muscles compared to the more superficial muscles. We saw that females have higher intramuscular fat than males, and intramuscular fat is related to age as well as body mass index. And so being doing this sort of analysis in 84 participants would really not be possible without the development of these automated methods. We've begun to expand our methods clinically, specifically in patients undergoing surgery for cervical myelopathy. Here we show higher longus coli capitis intramuscular fat in degenerative cervical myelopathy group compared to controls. And intramuscular fat was higher in those that did not recover following surgery and was correlated with surgical response. And this line of research aims to improve surgical planning and trajectories of surgical recovery. It also could help support prehabilitation to try to improve muscle health prior to surgery to help increase the benefit to risk ratio. Due to technical barriers and limited access to large data sets, clinical studies investigating muscle health and spinal pain have been limited to smaller sample sizes with reduced heterogeneity. And this really has hindered our mechanistic understanding of the relationships between muscle health, spinal pain, and spinal function. So this next study, we kind of scaled up our work to be able to assess this relationship at more of a population level. And we trained and tested a computer vision model for the lumbar spine, which we applied to more than 10,000 images from the UK Biobank. So the UK Biobank is the largest prospective medical research study conducted to date, enrolling more than 500,000 participants from the UK, with a large portion having fat water abdominal imaging. And in about 15,000 of those participants with muscle imaging, we assessed muscle health, which is really not possible without AI. The analysis took 3 days with these models. I estimate it takes somebody 3 years working 24 hours a day without AI. And then we were able to do this with very high accuracy, excluding less than 1% for poor model performance. In a subset of this sample, with and without back pain, we see evidence of decreased muscle size and increased intramuscular fat in the lumbar paraspinal muscles in chronic back pain, with a graded relationship with back pain duration. So this demonstrates that even at this large heterogeneous data set, we see decreased muscle health in low back pain, supporting a mechanistic role in the maintenance of back pain, but it could also be due to generalized deconditioning due to having chronic pain. Next, we sought to assess the spatial distribution of muscle fat along the superior to inferior axis, so from L1 to L5. And we saw muscle-specific patterns of intramuscular fat. In particular, we saw this interesting sawtooth pattern in the lumbar multifidus. And then intramuscular fat, is higher at the lower and with intramuscular fat being higher and lower at the lower and upper end plates, respectively, with the greatest change in intramuscular fat at the upper end plate. And additionally, this kind of points to that being methodologically, it's important to be consistent where you measure intramuscular fat, as it does vary significantly along the spine. We've already extended our methods to patients undergoing surgery for lumbar spinal stenosis with neurogenic claudication. And we just demonstrate that increased intramuscular fat in the lumbar multifidus is associated with poor outcomes. So in red here are people with severe intramuscular fat. And in green are people with non-severe intramuscular fat. So this is similar to the myelopathy study that this line of research highlights the importance of muscle health and surgical outcomes for spinal conditions. So we've been working to expand our modeling really to the whole body. And we have made a freely available toolbox, an open source toolbox called the Muscle Map Toolbox, which contains tools for muscle segmentation as well as tools to assess muscle size and composition. We started with region-specific models. So we have, where did we start? We started with the cervical spine, then we moved into the lumbar spine. We've also moved into the pelvis with the abdominal muscles, shoulder, forearm, leg, and now have a thigh model and a foot model too. But we've just released just more than a year ago, we released our first whole body muscle segmentation model. It currently contains 99 muscles and bone labels, and we're continuously adding additional labels to the model. And we're working to finish the upper limb, face, pelvic floor, and abdominal muscles. So if you have a need, let us know. We can work with you to develop the tool for your needs. In addition to analysis tools, we're also leading a collaborative project to develop a rapid, standardized, multi-vendor whole body MRI protocol. You can scan this QR code to learn more and even join, contribute to the project. But in 15 minutes, we're able to get a whole body image to be able to assess muscle size and composition. And we have this protocol available for GE, Siemens, and Philips MR systems, and happy to work with you to get it working on your system. In addition to being able to segmentation tools, we're starting to work towards tools that can allow us to better assess the spatial distribution of fat. In that UK Biobank paper that I mentioned, we saw very differences in the distribution of fat as you moved superiorly to inferiorly. And that was just along one axis, but obviously these muscles are three-dimensional. And so we have developed and released as part of the Muscle Map Toolbox a muscle template where we averaged almost, I think, around 70 people's T2 weighted spines together. So we like mush them around until they align, and you can create these really nice, highly detailed anatomical images which represent the mean of a group of people. And then what we can do is we can take an individual's fat map and warp it to this template. And we can do that for, and as many people as we want. And then across that group of people, we can look at the distribution of fat in 3D. This technique is called spatial parametric mapping. It's commonly used in brain imaging analysis, and we're beginning to try to extend it to muscle analysis. And I guess here's just this is an average fat map across from the UK Biobank. So it shows the distribution of fat across 5,000 pain-free participants from the UK Biobank, and you can see that the location or the distribution of fat is different across the muscles. Especially there's much higher fat in the lower lumbar levels than there are at the more superior levels. Psoas major has very more homogeneous fat than the other rector spinae or multifidi. And what we've done is in the same group of people from the UK Biobank, we're starting to look at where are the age effects distributed, where is BMI effects distributed, where is physical activity, and also where are these sex effects. These are all well known to exist within the muscle. And commonly we look across the entire muscle, right? And we may correct for age, BMI, physical activity, and sex. But what happens if these effects aren't homogeneous across the muscle? It's interesting. I don't know what it means yet, but what we're seeing is that these effects don't appear to be homogeneous and seem to be distributed. We're just starting to put this manuscript into preparation. We'll be presenting, submitting the manuscript for a preprint soon. But it's really interesting in that the location does not seem to be homogeneous. And then we're able to use the participants with chronic back pain from the UK Biobank and compare their intramuscular fat to people with no pain. And so this is the distribution of group differences in intramuscular fat with people with chronic back pain versus no pain in the UK Biobank. Depending on the statistical methods we use, we're only here showing evidence of increases in intramuscular fat. We don't see any evidence of decreases in intramuscular fat. But there does seem it's not homogeneous across the entire muscle. And so perhaps different parts of the muscle are being affected by chronic pain um, differently, or at least the intramuscular fats may be being localized to certain areas with back pain. Next, I'm going to move out of the muscle work that we're doing and pivot into complementary work that we're doing with spinal cord imaging. And so first, we collaborated on a large multi-site study led by Dr. Julien Cohen-Adad at Polytech Montreal, harmonizing spinal cord imaging across multiple MR vendors. So we now have similar methods to brain neuroimaging to perform high-resolution 3D structural imaging of the spinal cord, as well as capture measures on gray matter volumes, myelination, spinal cord tract damage within the cord. We've also trained similar convolutional neural network computer vision models for automatically identifying the spinal cord from images. We trained models specifically for functional MRI, which has allowed us for near full automation of our spinal cord functional MRI analysis pipelines. We've also developed robust structural spinal cord segmentation models that perform across imaging contrast and in people with spinal cord lesions, as well as spinal cord compression. So using these tools, we can assess the shape of the spinal cord with high accuracy in 3 dimensions. We can measure cross-sectional area, anterior-posterior diameter, transverse diameter, and then other shape metrics. Not shown here, but we also have tools to automatically identify the spinal canal, so you can assess the cord to canal ratio measures, such as like the spinal canal occupation ratio. So we've applied this technique in cervical myelopathy. Here we're showing cross-sectional area of the cervical spinal cord along the superior inferior axis. So here's C2 down to T1, and then this is cross-sectional area here. In blue, you can see the distribution of healthy controls, which peaks around C4, C5, which is the center of the cervical enlargement. In myelopathy, we see noticeably decreased cross-sectional area with evidence of compression at the intervertebral disc levels. So it's kind of visually striking and just a great example kind of the capabilities of quantitative MRI techniques for the spinal cord. We've also applied this in people with radicular symptoms, and we show similar but smaller decreases in cross-sectional area, but still showing the greatest compression at the disc levels. The healthy controls here are better matched than the previous slide, and then you can even see some evidence of compression within the healthy controls here. When analyzing data from a previous functional MRI study in fibromyalgia, anecdotally, I felt that the fibromyalgia participants had much more than expected degenerative changes than their age-matched controls. And these are very preliminary results in a project being led by Dr. Dario Pfeiffer. But we're seeing some evidence of greater spinal cord compression in fibromyalgia, suggesting that perhaps an underlying spinal injury may partially explain the symptomatology within at least a subset of fibromyalgia patients. We're collaborating with Dr. Catherine Martucci here at Duke to confirm these findings in an external data set, and those analyses are also underway. Last year, we also released a model to automatically identify intramedullary lesions in traumatic spinal cord injury, as well as degenerative cervical myelopathy, allowing you to identify the lesion. You can see how big it is. You can see how much spared tissue is left. And then we've also developed a technique that can allow us to quantify damage to specific spinal cord tracts. So here's an example in traumatic spinal cord injury, where we can identify where the lesion, use a template to identify where in the cord we're seeing damage. And here in a small set of patients with traumatic spinal cord injury, we were able to show that people with the damage to their right lateral cortical spinal tract correlated with their right lower limb function, and similarly damage to the left lateral cortical spinal tract correlated with left lower limb function. In a larger clinical study data set, we've now replicated these findings, and we've also shown similar relationship with sensory scores and dorsal column damage. In addition to that, we're investigating the relationship between these measures with bowel and bladder control. We've just begun to apply this to cervical myelopathy to automatically detect and quantify the size and shape of the intramedullary hyperintensities in myelopathy. Here we show evidence that the volume of the lesion is associated with the severity of myelopathy based on the MJOA. And we're beginning to use these methods to also inform and optimize the use of spinal cord stimulation to restore standing and walking in spinal cord injury. One second. Okay. So kind of gave you an overview of kind of what we can do with these new computer vision models to be able to quantify information about muscle health and spinal cord pathology. The last topic that I'd like to discuss, which we hope can help translate these quantitative MRI measures into clinical practice, is normative modeling. So the results I presented so far are derived at the group level and provide information on potential mechanisms. But as clinicians, we want to be able to make inferences at the individual patient level. And this is what normative modeling can allow us to achieve. So let's do a quick case study as an example. Let's say you have a 65-year-old right-handed Latino male patient. He's complaining of neck and right arm pain, tingling and numbness in the hands, and dropping things. You do your standard history, your physical exam, and you decide to measure the patient's grip strength. And his right grip strength is 45.3 pounds. That's what you record. So what does this mean? It's not obvious to me. A big challenge is that grip strength can vary depending on age, sex, handedness, ethnicity, race, height, weight. What we're asking, is, how does his grip strength compare to another 65-year-old right-handed Latino male, or just the population of 65-year-old right-handed Latino males? Is this normal? Is this weak? And if so, how weak is this patient's grip? And we're really trying to determine, where is this patient on this bell curve after accounting for age, sex, and other demographic variables? Are they normal? Normal here? Are they strong? Are they weak? So to accomplish this, we can train a model using age, sex, height, weight, ethnicity, and race to predict somebody's normal grip strength. We can then compare the measured grip strength to the predicted grip strength and quantify how far a patient's measure deviates from normal. Fortunately, the NIH has invested in this space, and we have normative models available for some motor tests. And if we use the NIH toolbox, I can tell you where this patient stands relative to the population. And it turns out that he has very significant weakness, with 95% of the population expected to have higher grip strength than him. So we're expanding this normative modeling approach to our imaging data to be able to derive individual level inferences and replace the current spinal pathology grading of mild, moderate, severe to a more quantitative, granular, and objective measure. So we've been training normative models to predict measures like spinal cord cross-sectional area using age, weight, sex, our MR vendor, and height. Right now, we're training on more than 500 healthy participants. We're working to growing this to as many as possible. Here's an example of how we've applied this to myelopathy and healthy control patients. The left plot here is the participants' cross-sectional area, Z-scores, at the C2 to the C7 vertebral levels. You'll see that red is the myelopathy patients have very negative scores here, indicating decreased cross-sectional area, while the healthy volunteers in blue are centered around the mean of 0. And if we use a diagnostic cutoff here of -2, we can diagnose myelopathy with very high accuracy. And if this holds true, this is just improved sensitivity, potentially improved sensitivity and specificity for diagnosing clinical myelopathy, from imaging alone. Next, we want to be able to, how can we use this information at the individual patient level? And I'll just present two cases. So this is a myelopathy case and the image shows evidence of compression at C5, C6, and C6, C7. We can make a plot of their normative cross-sectional area scores, and we can see that the spinal cord is most compressed at C5, C6. I'm not a neurosurgeon, but perhaps this is then where you're going to want to target your discectomy and maybe laminectomy. And we believe that this could help with pre-surgical planning and determination there. Next is a myelopathy case, but we don't see.
Ken, you're currently muted. I'm wondering if you can unmute. Ken, you're currently muted.
Oh, okay, sorry, there are
There you
two
go.
buttons popped up. Yeah, good. Now you can hear me? I just stopped here, I assume, right?
Correct. Yeah.
Okay. So this is another case of myelopathy where we don't see strong evidence of compression here, but if you look on their plots of their z-scores for cross-sectional area, we see evidence of spinal atrophy across the cord. And I don't know what's going on here. This could represent a subtype of myelopathy that we just don't understand well, but it's an interesting case to point out. So cross-sectional area is just one shape metric, but there's much more that we can assess. And then we're expanding this technique to canal shape, intervertebral discs, nerve roots, and also muscle. So as discussed, muscle health has been shown to vary in different chronic pain conditions. I think one of the challenges is that we don't know necessarily, are these muscle changes due to their low back pain, or is it that they've had chronic back pain and they're now not as active and it's more of a deconditioning? At least that's a question that I have. And one of the challenges is that a back pain study will look at the back muscles. A knee pain study will look at the knee, muscles around the knee, but we haven't really looked how pain is influencing muscle health at a more whole body level. And so this study is going to get submitted this week. Preprint should come out by the end of the week. But we've used the UK Biobank again, and in addition to looking at using their abdominal imaging, we've expanded to pelvic imaging and thigh imaging as well. And we want to see our changes in muscle health, chronic pain condition specific. So we have applied our computer vision models to the UK Biobank and looked at muscles in the abdomen region, pelvis region, and thighs. And we've developed normative models using age, weight, sex, and height to predict muscle volume and intramuscular fat across 42 different muscles. We train these models on pain-free participants, and then I've applied them to chronic pain conditions. And so this plot here is a radial plot, maybe a little bit complicated, but of patients of their z-scores, so their deviations from normal, group level deviations from normal for chronic back pain. Here we have pelvis muscles here, abdomen muscles here, and thigh muscles. For muscle volume, more blue means that these muscles are atrophied. For intramuscular fat, more red means that these muscles are fattier. And so we're seeing the greatest signs of atrophy are in the abdomen muscles, as well as the greatest increases in intramuscular fat are in the abdomen muscles, which is also the lumbar paraspinal muscles. If we look at hip pain, we see a different sort of pattern of these changes in muscle health, more widespread evidence of atrophy, including abdomen, pelvis, and thigh muscles, as well as changes in increases in intramuscular fat. And strikingly, if we look at chronic knee pain, we see that these changes are highly localized to the quadriceps, where we're seeing evidence of atrophy in the quadriceps and increased intramuscular fat in the quadriceps. So for me, it's getting, let me go to the next slide first, sorry. We're then going to show a plot of people with one chronic pain site versus two chronic pain sites versus three chronic pain sites. And so in general, you're seeing as you have more chronic pain sites, you're having greater deviations from normal whole body changes in muscle health. And for specific pain, it looks like the muscles surrounding the region of pain are the most affected, which I think suggests that it's less about deconditioning, perhaps, but there's something happening that's more mechanistically related to their pain condition. We can talk more about that. In addition to these are kind of just next steps and directions that we're going. In addition to that, we're working on expanding our spinal cord work to vertebrae and to discs, and working with collaborators in Canada and at Polytech Montreal. But we have tools now available to automatically identify vertebrae, discs, canal, spinal cord, where then you can create these 3D models. Spine Reports is available. It's a tool available as part of the spinal cord toolbox where you can create these 3D models, you can create these assessments. We're even able to now extract information on the intervertebral foramen and understand and quantify its cross-sectional area. And we're starting to move this into clinical trials as sort of secondary measures to understand mechanisms. And this is a collaboration with Dr. Nathan Shalati at University of South Florida. He has a DoD grant looking at traction for chronic low back pain. And we're doing our imaging before treatment and post-treatment, and going to look at how how traction affects these measures and correlates with symptom outcomes. And we also have there's a sham traction arm as part of that study. I believe they just finished recruitment, and so it may be a great talk at sometime in the near future to have Nathan come and present preliminary results. And then in addition to that, I mentioned intervertebral foramen, but we're also getting at automated spinal rootlet segmentation. And we have this developed in and working well in the cervical spine. Still need to expand it to the lumbar spine, which is currently a work in progress, but be able to segment out the cauda equina and then be able to look at cauda equina compression within the lumbar spine and apply this in lumbar spinal stenosis as well as radiculopathy. So just to bring it all together, we can now quantitatively assess muscle, neural tissue, bone, and discs like never before. And bringing this together, here's an image that you may have ordered in your practice. And while you may get this narrative report, there's just so much more information in that image that we're just starting to measure using these new advancements in AI-powered computer vision models. And with this information and tools, I think we can have higher efficiency on the radiology side, but I think more importantly is having a more accurate and comprehensive understanding of the mechanisms of spinal conditions. And with this information and using tools like normative modeling, we'll hopefully be able to provide a better diagnosis, patient-tailored treatment plan, and prognosis, kind of all with a high level of confidence, and kind of moving us towards an era of precision medicine for spinal conditions. So we have these tools available. They're all being made open source. I want to get into manual therapies and start applying them to understand mechanisms. I'm here to collaborate on the technical aspects. I need your expertise in manual therapies to apply them in that space, but I think there's a lot of opportunity here, and I'm happy to discuss this more and hear from you. So just want to say thank you.
Ken, that was great. Wow, I think you're seeing the expressions of gratitude from the many watchers we've had. Really, really wonderful job. I love the fact that you're quantifying biological contributors to spinal and general musculoskeletal pain, exactly what we needed. We do have some questions flying in. I'm going to start with Micah's question first. The question is, much of the muscle applications seem to be in fat fraction. Any interesting findings with T1 row, T2, or other sequences?
Yeah, so the just classic T1, T2 weighted imaging we've looked at. There's a challenge there in that MRI is kind of not quantitative enough. And to quantify volume and size, you're okay with conventional T1, T2 weighted imaging. To get at fat, you have to set some sort of threshold to decide what is fat, what is muscle, and that can be problematic. We are doing some diffusion imaging. We've done some diffusion imaging in the forearm, and it looks like in myelopathy patients, we're seeing that the diffusion imaging is sensitive to changes in muscle microstructure in these myelopathy patients compared to healthy age-matched controls. We're not seeing a difference with fat fraction within this myelopathy group. We
Good.
haven't done I haven't done any T1 row or anything like that. There's people here at Stanford doing some more advanced techniques in PET imaging as well there.
And the questions are flying in. We'll rapid fire these to get them out. Former ForceNet speakers Casper and Martha ask, do you think these techniques could be used for opportunistic screening of degenerative medullary lesions like degenerative cervical myelopathy or even more common degenerative degenerations such as disc herniations? It might be a bit early, but based on your data, what do you think the future looks like?
Yeah, no, I definitely think so. We are the spine reports will output sort of quantitative scores on shape changes as well as intensity differences within the intervertebral discs as an example, and those measures are correlating with Furman grade. And we're starting to link them to clinical outcomes as well. So they're there. It's going to take some time before they're as well validated or as accepted as sort of the classic grading system. So I think it'll take some time there, but it is possible. The lesion segmentation tool is working well in myelopathy patients and being able to detect intramedullary lesions there, and we're not seeing much in healthy volunteers. We're seeing much lower detection rate, I guess. But yeah.
Here's one from Kelsey. Do you have any plans to try MR elastography for paraspinal muscles?
Yeah, so it's in my queue of things that we'll hopefully get to at some point, but we haven't done it here. It's been discussed. It's more trying maybe to find the postdoc who wants to really spend some time trying to figure that out and test it out. But it's possible. It definitely be of interest. I don't know. Yeah, I feel like it definitely would have a lot of potential for myofascial pain, maybe acute sprain strains, chronic, looking at manual therapy effects, and those aren't areas that we've moved into yet. So that's another thing too. We just don't have funding in that space.
Another question, have you considered looking at both the canal and the foramen in different mechanical contexts? For example, flexion versus extension, standing versus supine.
Yeah, we've discussed this. We've done a little bit. It wasn't my work, but the collaborators that are doing some of the spine imaging work, looking at more cord shaped and potentially canal shapes with flexion and extension of the neck. Largely more though from the technical aspect and how to optimize our imaging to better image the cord. It's all possible. We had during my PhD, we're going to try to do like kinematic MRI, and we had this big contraption where we could rotate people's heads and look at movement, movement kind of with MRI. It was really complex, but at that time, I couldn't manually segment the images well enough. We had that data, we'd apply it, could do it again, and reassess that. There's a challenge there with people are heavy and trying to position them in a scanner and hold it can be difficult. But our technique should work on like standing upright imaging that is close to what's kind of conventionally done, I think.
So, a question from David, have you done any pre-post evaluations of spinal muscular fat content after core reconditioning?
Yeah, we had it's in one of the spine journals, but we did a review paper on exercise effects on intramuscular fat. And largely because there was a lot of methodological issues with how we measure fat, which has led us to try to improve these measurements. It's, it's not, we don't know, I don't know how much these things change with exercise. I guess there's a lot there that can be explored. We haven't done a longitudinal study yet with our group. There is some work being done with hamstring injury here at Stanford that I just was in on a talk, and they've looked at pre-post changes longitudinally, but we haven't yet. We are interested in looking longitudinally in myelopathy and lumbar spinal stenosis to try to better understand who has motor loss and why, how spinal injury can affect muscle. So it's of interest. We just haven't done it and haven't gotten the funding for it yet.
There's Forcenet friend Samuel asked, are you collaborating with the people in Stanford at the Neuromuscular Biomechanics Lab? It seems there is a possible connection between your work and musculoskeletal models like OpenSim.
Yeah, so there is Anusha Pai, just finished her PhD, but she's going to stay on as a postdoc. And they're part of her effort is going to be trying to incorporate these muscle imaging measures into OpenSim to have more personalized modeling. Um, we'll provide the segmentations as best as we can, the OpenSim, and then also getting it integrated into OpenCap is a goal. But they'll be doing most of that and hopefully leading it forward. But it should be in an open source fashion at some point that potentially then others can use it for their research. But it's a goal for sure.
So both Greg and Bill ask a similar question regarding longitudinal monitoring of patients, asking, have you seen any interesting changes across multiple time points if you've actually captured that? I think you touched on that earlier.
Yeah, we don't have a lot of longitudinal data. We are starting beginning of May. We are having a new study starting up that's a 5-year study where our goal is that all patients coming in with myelopathy and radiculopathy into neurosurgery, we're going to collect motor assessments, outcome measures, and curate their clinical imaging data, and then be able to have that data set build up over 5 years to look at how myelopathy progresses over that time.
Hey, if you don't mind, I have a question regarding myelopathy. As a diagnostic accuracy researcher in that given area, we have frequently been held to using myelomalacia as our confirmation of myelopathy, which to me would seem like in more severe cases. Do you think your cross-sectional model would be a more accurate reflection of someone with DCM?
Yeah, so trying to like identify the
Yes.
lesion and using that as a to quantify it
Yeah.
or to define it.
To
It
define it. Yeah. Clinically
yeah.
diagnosed.
The I know there's a lot of it's hard to define when is something myelopathy, when is it radiculopathy,
Yeah.
and I think that could be a diagnostic criteria. But I know you and there's like the read code DCM. A lot of people in that space. I think that certainly could be improved, and it would be worthwhile. I think looking into it to see if it can help.
Yeah, I work with the Recode folks too. They're doing great work. So it's interesting. You seem to have embraced AI and training the models. What would you say to those individuals? And I've heard this probably 10 times that AI will replace radiologists, et cetera. I think it will enhance their work. What would you say to something like that?
Yeah, I think it's going to change their work, and I think we can now measure so much more in the image. It's going to be a while till we can understand how to use this new knowledge and relate it to patients and help it to guide care. But I think it's going to make their job better. We are far improving what they're doing, what we can do, and I think radiologists are going to appreciate having more objective tools. And at least in my conversations, I'm not a radiologist, but is it a mild? Is it moderate degeneration? It'd be better if you had a metric and you didn't have to sort of make that grading, right?
Totally agree. And just a reminder to our participants, if you have a question, you can drop it in the chat. We still have a couple of minutes left. I do have another question for you, if you don't mind. Um, and we've done some work on fat content in the rotator cuff musculature and then outcomes. Do you see any potential pitfalls in that line of research using imaging variables and connecting or correlating those essentially to patient-reported outcomes?
Hmm. We have done a little bit of shoulder imaging modeling now. Brian Kim, who's at the University of Sydney, is leading those efforts. I don't know a lot of the clinical space there outside of improving the modeling. There are some challenges as far of with like tears and how would we, if there was a tear, how would we quantify fat there? Would our models work really well if it's a severe tear versus a mild tear? And I'm not sure that they will fully generalize to um, all these different types of pathologies that you could see. And that one challenge is just trying to have the data organized in a way that we can use it, as well as labeled in a manner that we can train these models. And that's still a challenge. So not sure if that answered your question, Chad, but yeah.
Oh, it certainly did. And it looks like we have, I mean, I could ask you 1,000 more questions, but that's not why we're here. But this was an exceptional presentation, and we really do appreciate you coming on. And on behalf of ForceNet, thank you so much. As a reminder, folks, we'll put this on our YouTube library so you can watch it again or ask others, share the link. Thank you once again and uh, keep stay tuned. There'll actually be more ForceNet webinars in the future. Thank you very much.
All right. Appreciate it. Thank you.